Let's jump right into this explainer and transform a massive mountain of pediatric clinical data into your ultimate priority playbook. You already know that when we're dealing with pediatric patients, the stakes are just incredibly high, right? Recognizing that subtle, split-second shift from normal development to a life-threatening emergency is absolutely everything. So today, we're taking a vast array of clinical notes and distilling them straight down to exactly what you need to know to triage effectively and keep your patient safe.
We'll be moving through 5 main areas today: growth and developmental milestones, airway and respiratory emergencies, congenital heart defects, gastrointestinal and renal priorities, and we'll wrap up with the critical pediatric never-dos. Let's get right to it.
Section 1. Growth and developmental milestones, establishing the baseline. Okay, to really master pediatric milestones, you have to see how Piaget's cognitive stages completely align with Erikson's psychosocial conflicts. Think about how these domains interrelate. Take an infant in their first year of life. They're in Piaget's sensory-motor stage, right? Learning entirely through physical touch and their senses. But right alongside that, they're navigating Erikson's crisis of trust versus mistrust. This means, as a clinician, your physical care, like how consistently you respond to their cries or just how you hold them, is literally teaching them whether the world is a safe place. Then, as we move up to toddlers, you see that shift to pre-operational symbolic thinking combined with autonomy versus shame. That's exactly why offering a 2-year-old a couple of limited choices instead of firing off yes or no questions completely changes the dynamic of your care.
Now, when it comes to physical milestones, any deviation is a massive, high-stakes red flag. You absolutely must have this memorized. Birth weight doubles by 6 months and triples by 12 months. If an infant isn't hitting those marks, you're immediately looking at failure to thrive or a potential chronic illness. And think of the fontanelles as the brain's built-in expansion joints. The posterior one closes early, usually around 6 to 8 weeks, but that anterior one stays open way longer, until 12 to 18 months. If you find that anterior fontanelle open past 18 months, or if you're assessing a child over 2 years old whose head circumference is somehow still larger than their chest, man, those are major neurological red flags. They point straight towards serious issues like increased intracranial pressure or macrocephaly.
Section 2. Airway and respiratory emergencies. The A and B of pediatric triage. So let's talk about 2 clinical lookalikes that demand entirely different responses. First up, croup. It's viral, it creeps up gradually, and it has that classic barking seal-like cough. It's definitely scary for the parents, but we often manage it with basic comfort measures, cool mist, and maybe a steroid. But then, contrast that with epiglottitis. This is a bacterial emergency, folks. It hits suddenly, out of nowhere, and the child will show the 4 Ds: dysphagia, dysphonia, drooling, and distress. If you see a child with a high fever, leaning forward in a tripod position, and they literally can't even swallow their own saliva, you are looking at a hypercritical airway emergency.
Moving on to bronchiolitis, which is mostly caused by RSV in infants under 6 months. Your management strategy here is purely supportive. You're going to see tachypnea and expiratory wheezing as their tiny little bronchioles get totally obstructed with mucus. So what do? We elevate the head of the bed, gently suction those nasal passages before feeds, maintain their hydration, and provide oxygen. But honestly, what you don't do is just as crucial. Evidence clearly shows that bronchodilators and corticosteroids are simply not effective for routine bronchiolitis. So don't reach for them. Just focus on clearing that airway and supporting the infant's own respiratory effort. Sticking with the airway, what happens when it's totally obstructed by a foreign body? Well, in a pediatric airway, a child's first birthday is basically the magic switch for your intervention. If you've got an infant under 1 year who is cyanotic and completely silent, meaning a total obstruction, you never, ever use abdominal thrusts. Instead, you place them face down on your forearm, deliver 5 firm back blows, and then flip them over for 5 chest thrusts using just 2 fingers. But the literal second that child turns 1 year old, their anatomy and the guidelines shift. That's when you move straight to the Heimlich maneuver, standing behind them to deliver inward and upward abdominal thrusts.
Section 3. Congenital heart defects. The C of pediatric triage.
Let's break down the 2 main defect categories based on blood shunting. For acyanotic defects, like ventricular septal defects, you're dealing with a left-to-right shunt. Because the left side of the heart naturally has higher pressure, blood gets pushed backward into the right side, which basically overloads the lungs. Now, it's bad, sure, but it doesn't immediately turn the child blue. Cyanotic defects, on the other hand, are a whole different beast. These are much more dangerous. Here, the pressure pushes deoxygenated blood from the right side directly into the systemic left side, skipping the lungs entirely. This right-to-left shunt means deoxygenated blood is just pumping straight through the body, leading to immediate systemic cyanosis.
And that brings us to a literal life-or-death clinical question you absolutely must know the answer to. Tetralogy of Fallot is a major cyanotic defect, and infants with it can suddenly experience what's called a TET spell. This is a hypersonic episode where their oxygen drops dangerously low, and it's often triggered by something as simple as crying or feeding. So how exactly do you intervene?
Well, here is your exact protocol. Step 1 is your absolute non-negotiable priority. Place the infant in a knee-chest position immediately. Why does this work? By bringing those knees up to the chest, you physically kink the femoral arteries. This causes a massive sudden spike in systemic vascular resistance. All that high pressure in the body pushes back against the heart, forcing the blood away from that dangerous right-to-left shunt and back into the pulmonary artery where it belongs, so it can actually get oxygenated. After you do that, you apply oxygen, keep the child as incredibly calm as possible because crying just spikes their oxygen demand, and then notify the provider.
Section 4. Gastrointestinal and renal priorities. High-yield systemic disorders. When it comes to pediatric GI issues, you have to be able to instantly link classic presentations to their definitive interventions. If you see sudden, severe colicky pain paired with current jelly stools, which is essentially blood and mucus, you're looking at intussusception, where the bowel actually telescopes into itself. The fix? An air enema. Or if you're assessing a baby with jaundice lasting well beyond 2 weeks, passing these pale, clay-colored acolic stools, you are looking at a massive medical emergency called biliary atresia. Their bile ducts are blocked, and they need a Kasai procedure before 60 days of life to save their liver. For celiac disease, which shows up as diarrhea or fatty stools, they need a lifelong, strict gluten-free diet to stop the autoimmune destruction of their intestinal villi. Meanwhile, lactose intolerance is really just a missing enzyme, so that just requires lactase supplements or dietary avoidance.
Moving to the renal system, your absolute top priority is hemolytic uremic syndrome, or HUS. This nightmare usually starts with a child eating some undercooked beef, contracting an E. coli O157H7 infection, and suffering through a bout of bloody diarrhea. But then, days later, they suddenly crashed into this classic triad: anemia, thrombocytopenia, and acute kidney injury. The Shiga toxin essentially destroys their red blood cells, chews up their platelets, and totally wrecks their kidneys. A great memory trick here is the acronym HATE: hemolysis, anemia, thrombocytopenia, and encephalopathy, or AKI.
Section 5. Critical Pediatric Never-Dos. The ultimate survival mandates.
Okay, number 1. If you see a 2 to 5-year-old kid with a firm, painless mass on one side of their flank, you should immediately suspect a Wilms tumor, which is the type of kidney cancer. And listen to me, you must never palpate that abdomen. You literally need to post a warning sign on their bed. Think of a Wilms tumor like a highly fragile water balloon. Just manipulating the abdomen during an exam can rupture that thin outer capsule, instantly spreading or seeding malignant cancer cells all throughout the child's body.
Number 2 ties right back to our airway emergencies. If you see that drooling, feverish child sitting in a tripod position, you never inspect their throat. No tongue depressors, absolutely no oral temperatures, and don't even think about trying to give them a sip of water. Any stimulation of that highly inflamed pharynx can trigger a sudden spasm, causing the airway to snap completely shut. You only look in that throat if you are standing in a fully controlled OR setting with intubation equipment ready to go.
Let's round out this critical list. First, never give a child with chickenpox or varicella aspirin. Doing that carries a massive, terrifying risk of triggering Ray's syndrome, which causes fatal encephalopathy and liver degeneration. Second, for those HUS patients we talked about earlier, never give them antibiotics. Destroying the E. coli bacteria just causes it to release even more of that deadly Shiga toxin. And don't give them platelet transfusions either, because those fresh platelets will just get consumed by the microthrombi and make the kidney injury so much worse. Finally, if a child is choking, never perform a blind finger sweep. If you can't clearly see the object, your finger is just going to push it deeper and turn a partial obstruction into a fatal complete one.
Understanding these clinical priorities is really just the beginning of your journey. We've mapped out the baselines, the airway traps, the cardiac shunts, and those absolute non-negotiable deal breakers. So the real question is, how will you take this playbook, recognize these patterns instantly, and apply this knowledge to save lives in your fast-paced daily practice? Keep these priorities front of mind, and you'll be ready for absolutely anything. Thanks for diving into this explainer with me.